It's nice to meet all of you, and I appreciate you taking time out of your busy lives on a Saturday morning to come listen to us. I'm charged with the task of giving you an overview of cutaneous lymphoma. So I have to say it's a very broad category of diseases, and so I'll focus on the most common things. If I don't address your particular disease, please feel free to come talk to me afterwards, because I know that there's some rarer ones that we won't be touching upon. So, right. To start with, cutaneous lymphomas are classified as what we call non-Hodgkin's lymphomas by the World Health Organization. And the World Health Organization is an organization that categorizes cancers and what most doctors will go according to when they're diagnosing your disease. As you all know, cutaneous lymphomas in general are very, very rare. And there are two major groups that we like to talk about. There's the umbrella of cutaneous T-cell lymphomas, and then there's the umbrella of cutaneous B-cell lymphomas. When we talk about cutaneous T-cell lymphomas, the most common ones you'll hear, especially if you visited the Cutaneous Lymphoma Foundation website, are Mycosis Fungoides and Sézary syndrome. So that's what we'll focus on more today. And we'll also touch upon what we call CD30 lymphoproliferative disorders, and we'll talk about what that means. And in that category is lymphomatoid papulosis and primary cutaneous anaplastic large cell lymphoma. And then, of course, our B-cell lymphomas. So, cutaneous T-cell lymphomas make up 75 to 80% of all cutaneous lymphomas. Pretty much out of that, Mycosis Fungoides and Sézary syndrome are the most common in that category. For cutaneous B-cell lymphomas, they make up 20 to 25% of all of our cutaneous lymphomas. Now, as you can see here, the number and different types of cutaneous T-cell lymphomas is pretty large. So again, the most common types, Mycosis Fungoides, Sézary syndrome, and then our primary cutaneous CD30 lymphoproliferative disorders. There are other cutaneous T-cell lymphomas that we see just a lot more rarely, even more rare than Mycosis Fungoides. Subcutaneous panniculitis-like T-cell lymphoma is another type of T-cell lymphoma. Adult T-cell leukemia lymphoma is another type of T-cell lymphoma. And again, we won't be touching on those today, but if that's your diagnosis and you have questions, please feel free to talk to me afterwards. So the most common type, again, is Mycosis Fungoides. It accounts for half of all the cutaneous T-cell lymphomas alone. Typically, it's slow growing, as you saw in the introductory video with Brett speaking. It can present as patches, plaques, things that look like eczema and psoriasis, and some people can even develop nodules, which are raised lesions that I explain to most of my patients. It almost looks like a golf ball that maybe was cut in half and stuck on your skin. That's what we think of as a nodule. This is a nice slide that Dr. Kim, my mentor, shared with me, and I cannot outdo this slide, and I like to steal her slide, so thank you, Yun. And this is something that shows you the different types of lymphoma that we see and explains the stages a little bit better. So when we talk about patches, that's really demonstrated by the figure on the right-hand side to the top. So patches are stage T1, T2. So that's what we mean when we talk about patches or plaques. Patches are something you can't really feel, like you can draw your hand across it and you won't feel it, but you can see it. Plaques are when they're raised, so you can see it and you can feel it. And then we have tumors, which I said are a lot thicker, and you can feel them a little bit more deeply. And then the last one, what we call erythroderma, those are like patches and plaques, except they involve most of your skin surface area. So a lot of people in that stage will be red almost completely from head to toe. There is a blood form of Mycosis Fungoides, or what we refer to as the blood form, and that's called Sézary syndrome. And in that particular type of cutaneous T-cell lymphoma, people have extensive red, itchy rashes, so very much like the picture in my lower left-hand corner. So they're red from head to toe, and then they will also typically have the cancerous cells in their blood as well. They do have lymphadenopathy, which just means your lymph nodes, which are the collection basins for infection or cancer, can also be enlarged as well. So how do you know if you have mycosis fungoides when you're just red from head to toe versus Sézary syndrome? And it's basically your doctor ordering blood tests and checking the blood to see if there's a certain number of those cancerous cells in your blood. In previous years, it actually used to be a doctor who's a pathologist who would look under the microscope and see if they saw a certain number of cells and count them. And now we actually use more sophisticated technology in which we use a machine that does the counting and looks for certain cell surface markers. So symptoms that we see more so in Sézary syndrome than we would see in mycosis fungoides, you can see changes in the nails and the hair or the eyelids. And it typically affects people similar to mycosis fungoides around the age of 50 and over, although we have seen younger patients. And it's slightly more common in men than in women. For both mycosis fungoides and Sézary syndrome, we don't know currently of any risk factors for this, be it genetic risk factors or things that you've been exposed to. And so this is just another picture of someone with Sézary syndrome, and this was a person where we have to draw the blood to actually see if the cells are in the blood. Now, someone with Sézary syndrome can develop something called Erythroderma, which is thickening of the palms and soles, and it'll be a little bit waxier and thicker of a skin. Sometimes it'll be hard for people to close their hands, or it might be painful for someone to walk. They may also notice that their nails are getting thicker in addition to being just red from head to toe. Now, some people may see this and go, oh wait, I thought that was nail fungus. And nail fungus can look exactly the same. So this is a nail change in the setting of someone being red completely from head to toe and being red for a very long time. This is something called Ectropion, and what that means is I put a reference on the bottom is someone on the right-hand side in the picture with in the line with 3 pictures. That those are kind of the way normal eyes should look, but on the top you can see the red part where someone's eyes kind of has been turned out, and that's called Ectropion. And you can also see where they've lost their eyelashes, and so that can be difficult to keep the eyes wet sometimes, and so you might suffer from dry eyes. So how do we stage mycosis fungoides and Sézary syndrome? And there's a lot of confusion, I think, when it comes to that. There's been a system for quite a while now. What we do is we actually grade each what we call compartment of disease. So a compartment may be your skin is one compartment, your lymph nodes are another one that we grade, your internal organs are another one, and lastly your blood. Most of the people, yes, will definitely have skin involvement only, and so your overall stage is really determined by how much involvement you have of your skin. And so if you remember the pictures I showed earlier when we were talking about patches and plaques, so things you can feel versus not feel and see the difference on your skin, if that's less than 10% of your skin surface area, you would be someone that's a T1, so very early stage. If you have over 10%, but you're not red from head to toe, that's a T2. If you start to get some of those larger tumors on your skin, it's a T3. And if you're red from head to toe, that's a T4. And then your physician can also grade, like I said, the nodes, the internal organs, and the blood. And then what you basically do is you get your numbers from each of those and you drop it into this box, and it gives you the overall stage. So for mycosis fungoides, most of our patients are in what we call stage 1. So that means they wouldn't have any involvement of their nodes or their blood or their internal organs. and they'll have involvement of their skin only, and it'll be the patches and plaques. And if it's less than the 10%, you're stage 1A with a good prognosis. If you're a stage 1B, it means you have over 10%, but you're not red from head to toe. And depending on how the lesions look, you can have a good prognosis too. So moving on from that to the something that is not as common in the cutaneous T-cell lymphomas are what we call CD30 lymphoproliferative disorders. So what does that entire term mean? Basically what it is that it's a cell that carries a marker called CD30. And we wouldn't know that, like a dermatologist or an oncologist looking at you under your skin wouldn't know that you had that marker. They would typically be taking your skin biopsy, and the pathologist that looks at it under the microscope would actually do a special stain to look and see if your cells are expressing that and if they look a certain way under the microscope. Why this is important is because we have two different lymphomas called lymphomatoid papulosis and primary cutaneous anaplastic lymphoma that can express that marker. So what are these two things? Lymphomatoid papulosis is a skin condition in which you have these tiny little bumps, typically less than a centimeter, that come up and go away, come up and go away. Some of them can persist a little longer, but they do tend to come up in crops. They can be red with a tinge of brown in them, and sometimes they can have like a central erosion or ulceration in them. Typically, if they're going to regress, they regress in a few weeks' time, somewhere between the 2 to 8 weeks. Up to 90% of people that have this, it's self-limited, meaning that it goes and comes on its own and you may not need treatment for it, or the most you may need is a topical steroid. There are some people, though, that those lesions persist and become bothersome and ulcerate, and 10% of those people can sometimes develop another lymphoma, and that other lymphoma may be Mycosis Fungoides. So that's why we want to keep an eye on our patients that develop this and make sure they're not part of the 10% that develop something else. Primary cutaneous anaplastic large cell lymphoma. That sounds really scary because of the word large cell and anaplastic. But it's actually a very slow growing or indolent cancer. It can present as just one nodule or one tumor, or it can present with several. And they typically don't go away, so they typically need some sort of treatment. You may hear the terms anaplastic large cell lymphoma, especially if you were to put it in the Google bar. You'll get two different things that come up. And one is the primary cutaneous, which we're focusing on, which only affects the skin, doesn't typically affect other organs. But there's another type that's scarier that I think a lot of people think they may have when they hear these terms from their dermatologist. And that's the one that actually starts internally and starts in your lymph nodes, and it behaves very differently. For the primary cutaneous one, it definitely has a much better prognosis than the one that's systemic. It can affect people of all ages, although the most common age is between 45 to 60. And you see it more often in men than women. Again, similar to Mycosis Fungoides and Sézary syndrome, we don't have any known risk factors for this. And so this is a picture of someone who has primary cutaneous anaplastic large cell lymphoma. So you can see that these areas are much larger than the little bumps that we were seeing with lymphomatoid papulosis. And sometimes, as in this particular individual, there's a slight ulceration to the top of it. So necessitating, like sometimes we have to do some wound care and keep that area clean and dry. Okay, so moving on to the other category of lymphoma, cutaneous lymphomas, is cutaneous B-cell lymphomas. And so there are three major types. The first one is primary cutaneous marginal zone lymphoma. Then there's primary cutaneous follicle center lymphoma, and then there's primary cutaneous diffuse large B-cell lymphoma. And so these are the main two that we see most commonly. Typically for the first two, the marginal zone and the follicle center, They're nearly always indolent, so meaning slow growing. They usually appear as a reddish bump. Sometimes they can almost appear a little bit purplish. Most of the time when they clear up, about half the time they can come back. And it wouldn't necessarily come back in the same area. It may come in a different area. But we hardly, if ever, see it go to any other organs internally and no blood involvement. We see men and women affected equally in any age group. And again, just similar to all the other lymphomas that we've mentioned earlier, there's no known risk factors. So out of the two, primary cutaneous follicle center and primary cutaneous marginal zone, follicle center is the most common, and both of these can actually develop slowly over months to years. However, the difference is that most of the time, primary cutaneous follicle center, you'll see it on the head and neck area more so than your arms or your legs or chest, belly, back, whereas the opposite is true for marginal zone. You'll probably see that more on your extremities or trunk. So these are some pictures of primary cutaneous follicle center. And you can see this particular person has nodules or lumps on his head. And actually these are two different patients, but both of them predominantly have these lumps on their head. Whereas this particular person has marginal zone, and he actually has a smaller lump on his chest, and then some even smaller than the one on his chest on his arms. The last type of B-cell lymphoma is primary cutaneous diffuse large B-cell. And this one actually, in contrast to the previous two, is much more aggressive. So it grows a lot more quickly. We do have two types of it. The one we call leg type, and in that type we see it mostly on the leg, and it's actually mostly in women who are older. And when they grow fast, they can actually develop sores or openings on the top. And so that one we do worry more about because it can spread to other organs. And so we definitely get an oncologist involved very quickly. And so that's a picture. This one doesn't show that it can ulcerate, but this is how it can start. And we have the leg type, but we also have that we can also see in this lymphoma affect other areas of the skin on the body. So now that we've gone over a very whirlwind tour of the different and the most common types of lymphoma, how are you diagnosed? And I think that's probably the most confusing part, especially hearing over the years lots of patients say, well, you know, like I thought I had eczema, or I thought I had psoriasis, and that's what I was told. And then all of a sudden you're hit with, no, you really have a lymphoma. So what really needs to be done how are doctors coming up with these diagnoses? So I'll try and be as transparent as possible. First of all, it starts out with a history. It's your doctor sitting down with you and asking you questions about when this rash started, how long ago it started, does it come and go, if you've used anything in the past to treat it, or if you started any new medications before this all started. Doing a very complete physical exam, and I can't stress this enough, it's definitely getting checked from head to toe. So not just kind of where you have the rash, but having your entire skin surface checked, because there may be something subtle that you haven't noticed that your doctor may notice. And occasionally if they think that it's necessary, checking your lymph nodes as well. Skin biopsy. And this can be sometimes the most frustrating part. When we say skin biopsy, it sounds like, all right, my doctor's he or she's gonna take this piece of skin, and they're going to go look at it in the microscope, and they're going to tell me for sure what I have. And unfortunately, in very early lymphoma, particularly Mycosis Fungoides or Sézary syndrome, the findings that we see under the microscope are not diagnostic. And so it can be taking multiple biopsies, whether that means multiple biopsies in one day from different sections of the skin, or following you over time and having to take multiple biopsies. Until we find what's classic for it. Blood tests. So as I mentioned earlier, Sézary syndrome. So how do you tell the difference between MF and Sézary syndrome? You also have to get a blood test. So your doctor may be ordering that. If necessary, it's also combining your imaging studies, so meaning like getting a chest x-ray or scan. Very rarely do we ever need a bone marrow biopsy or a lymph node biopsy, but everybody's case is different, and so we have to look individually and see if that needs to be done. And then we have special tests that are done behind the scenes, so ones that you may not know about that are perhaps done on your tissue or your blood to help us see if maybe just with our naked eye looking under the microscope we're missing something. And so in very small print here, and you can find these on the National Comprehensive Cancer Network guidelines, this is what doctors look at when they're trying to make your diagnosis. So what they're looking for are particular things in your skin and your blood, and it's basically like making check marks and going down and seeing if we're seeing these particular markers expressed or you have these particular things expressed in your blood. So why are cutaneous lymphomas so hard to diagnose? And why have so many of our patients had to go through a very long story to get to their diagnosis? The first thing is it's just very rare. It's extremely rare. Most physicians that you talk to, if you talk to your general practitioner or even some of your other specialists that may be involved in your care, they've never heard of Mycosis Fungoides or Sézary syndrome or some of the B-cell lymphomas. And so the problem is just the rarity of it. The other thing though is that most of the time, especially the most common type, Mycosis Fungoides, it can be mistaken for a lot of other things, and it has a lot of overlap, whether just the doctor looking at your skin or even the doctor looking under the microscope at your skin biopsy. These diseases can look very much like common conditions. So, for instance, Mycosis Fungoides can look very similar to eczema or psoriasis. The diagnosis can take years to make, and that's where I was referencing sometimes like the findings aren't classic under the microscope, and so it's just someone cautiously following along with you, your physician following along and making sure that if anything changes, they do another biopsy. And unfortunately, at this point in time, we have no single one test, whether it be in your skin or blood, to say this is what you have. It's a doctor being aware that this entity exists, looking at your skin and comparing it to what they find in your blood and what they find under your skin biopsy. And so with that, I'll pass it off to our next speaker, but if you have any questions, here's my email. Please feel free to email, and I will be here for the rest of the morning, so if you have questions and I didn't address your lymphoma, I'd be more than happy to talk to you. So.
Thank you, Dr. Abdullah.